Welcome, everyone. My name is Akhil Saji, one of the editors of GU Oncology Now. We're here from the Western section meeting here in beautiful Kauai. I'm here with my good friend, Dr. Amir Lebastchi, who's an assistant professor at the Keck School of Medicine in Southern California. And he's an expert in all things focal therapy, probably one of the foremost experts in this field. He's published extensively on the topic, and he's been working on this since he was a resident at the University of Michigan and throughout his fellowship at the NIH. And he continues treating patients in Southern California today, and he's here at this meeting to give us his advice on this topic.
So, aloha, and thanks for having me. Thank you.
Thanks for being here. So we're going to cut right into the questions. So Dr. Lebastchi, could you give us a brief history of focal therapy?
Yeah, focal therapy has been around in the oncology world and GU oncology world for a long time. We all know ablation of renal tumors and cryotherapy of the prostate has been around for many years as well. In fact, it was grandfathered into the guidelines for patients who are not suitable for surgery or radiation. Cryotherapy has been an option as an alternative. So it was always around. More recently, there was an advancement of technology. So there are newer technologies in focal therapy, including HIFU, IRE, irreversible electroporation, TULSA, laser therapy, as well as many other that I'm not mentioning here right now, but there are a lot of other energy modalities that we're using to treat ablate prostate tissue.
Okay, excellent. Could you go over a little bit of the role of MRI and prostate cancer workup in your practice?
Yep.
And obviously, and what you use it for on a day-to-day basis?
Yep. Yeah, absolutely. So I think MRI made it possible that we see focal therapy as a good option for prostate cancer. We're able to see prostate cancer, so MRI visible cancer, better detect prostate cancer, better risk stratify our patients, and we know exactly where the disease is, so we can go directly to the area and treat the cancer. So I use MRIs before every first biopsy. I get the MRI, know exactly where I have to go, do a targeted biopsy, as well as a systematic biopsy. We published about that at the NIH in the New England Journal. It's always important to do a targeted as well as a systematic biopsy to look for the disease distribution. Is it only in the target or is it throughout the prostate? That makes us able to better risk stratify patients and select patients who are suitable for focal therapy.
Okay, and so in cancers that are non-MRI visible, what would be the role of MRI?
Yeah, so what is the role of MRI if it's not MRI visible? So maybe they're not visible yet, but because the pathology, the imaging lacks the pathology. So I like to follow patients if they have the low risk cancer over time with MRI, because maybe a cancer that is not MRI visible will be visible in the future and be targetable in the future. So I still continue in patients with low risk cancer using MRI, because we always know that imaging follows pathology, follows biology. So it takes some time to have changes on MRI.
Okay, very interesting. So could we briefly talk about what the current state of focal therapy is in prostate cancer treatment and the guidelines?
Yeah, so focal therapy right now is not fully endorsed by the guidelines. So focal therapy is an option in patients who are not suitable for other treatment options, for whole gland treatment options. You can consider focal therapy, but we need to tell the patient that it's still considered investigational at this time. But the guidelines are changing. They're waiting for long-term outcomes data. In Europe, they already see focal therapy as an option as long as it is in registries recorded. So it's very important that we collect our data, get a better understanding of how focal therapy works. So HIFU or cryotherapy, they're all approved for the ablation of prostate tissue, but not actually for prostate cancer at this point.
Okay. And so what would be the ideal focal patient in your mind?
Yeah, this is a very frequent question. So an ideal patient has an intermediate risk disease. I don't like to treat patients with low risk disease. I don't like to treat patients with high risk disease. The intermediate 3+4, 4+3 disease, it should be visible on MRI or PSMA PET scan. So be visible because you want to follow the disease down the line. it should be away from vital structures, and ideally it should not have any risk features like cribriform pattern or close to the rectum or extra prostatic extension. So those are, especially when you start out, you should start with an intermediate risk unifocal disease. It should be though disease that you need treatment, meaning Gleason should have some pattern for, so Gleason 7 and higher. I do not like, and in my practice, I don't routinely treat Gleason 6 cancer. So it needs to be a cancer that needs treatment, clinically significant cancer.
Mm-hmm. And do you treat grade group 3 and grade group 2 differently, or?
No, I use the same. In fact, I think grade group 2 and 3 is it's in the hands of the pathologists. You know how hard they sometimes look. So I treat them the same way. I like to do hemiablations, partly also because I want to treat one side and follow the patient. If he has disease on the same side, I know the treatment was not effective. So I use the same templates for treatment.
Got it. And could you briefly talk about the different, energy modalities? There's non-thermal techniques like IRE. There's also high-frequency ultrasound. Like, what do you prefer for which?
Yeah. So people have heard me talking about it. I like to divide the prostate in the northern hemisphere and the southern hemisphere. Look at the clock. Between 3 and 9 o'clock is the southern hemisphere. That's where the vast majority of prostate cancer are. I like to treat those cancers with a transrectal energy modality coming from below. Cancer located in the northern hemisphere from 9 o'clock to 3 o'clock, I like to treat with transperineal modalities, which is cryo and IRE. Now, you can treat patients in the southern hemisphere who have disease in the southern hemisphere with IRE and cryo. It's not an exclusion criteria. This is my practice. I prefer the energy modality coming from the rectum if it's posterior, because it's right there. And I definitely prefer patients who have disease in the northern hemisphere, meaning more anterior in the prostate. I like to treat with transperineal because it's a shorter distance to the tumor through the perineal skin.
Got it. Dr. Lebastchi, could you talk about the role of biomarkers in your practice? Obviously, we have PSA, but there's all these other biomarkers that are now circulating.
Yeah.
You have pre-biopsy tests like Exosome DX.
Yep.
There's Decipher, post-biopsy. Like, what do you use in your practice?
Yep. In my practice, there's always the pre-biopsy era. So does the patient need a biopsy? There are a couple tests out there, Select DX, My Prostate Score, ExoDX. Those are just to name 3 of them. I use to find out which patients actually need a prostate biopsy. Once the biopsy is done, and let's say there was a big target on the MRI and came back as negative, I can use a confirm DX to rule out that it looks into methylation of the tissue to see maybe we missed the cancer. So I use confirm DX in the post biopsy setting if I have a surprisingly negative test results. Now, once we come to the markers that we use for decision making, I like to use GPS, Decipher, and sometimes Polaris, especially GPS and Decipher scores. I like to get them for 2 reasons. One, these tests give me a better understanding how aggressive is the cancer. Is he actually a good candidate for focal therapy? I like to exclude patients with a high risk score on either of these tests for focal therapy. On the other hand, there might be a low risk based on pathology, low risk patients who really needs treatment. I would get a Decipher or a GPS score or Polaris to see, is there any more disease underneath that I didn't detect on my biopsy? So I like to use these tests for risk stratification.
Okay, very, very helpful. So Dr. Lebastchi, after a patient undergoes focal therapy with you, whether it's IRE, cryo, HIFU, or focal one, what's your follow-up protocol for these patients?
Very, very important that we keep the patient on a tight surveillance protocol, because that makes us more responsible for the patient. It's very important to follow patients to see which patients had good success and which not. So there was a Delphi consensus I co-authored. I was the first author on that, published in 2020, where we got a consensus on experts how to follow up patients. The overall consensus, the Delphi consensus, was to follow patients with PSA tests every 3 months for the first year. Like after radical prostatectomies, we follow them with PSA tests every 3 months, getting an imaging at between 6 months and 12 months after treatment, and that is subsequently followed with a with a biopsy. So biopsy between 6 to 12 months. Now, more recently, there is a push on waiting a little bit with the biopsy, especially if the patient had a great response. Maybe we can hold off of the follow-up biopsy for up to 2 years. But it's very important that we put these patients basically who are not suitable for active surveillance back on an active surveillance protocol. So we treat them and then put them on an active surveillance protocol, which includes biopsies as any active surveillance protocol. So yeah, I always say if the biopsy comes back negative, then put the patients on regular post-ablation surveillance protocol.
Okay, and that kind of leads into my next question. So once somebody is being followed up, what's your management of in-field recurrence versus out-of-field recurrence? Like, how do you treat those patients?
Yep. That was also surveyed among the experts in that Delphi consensus. And the overall consensus was you can still offer them a repeat focal therapy, maybe with the same or different modality. So if someone had, let's say, treatment more of the posterior aspect of the prostate and the recurrence was in the anterior, you might go and just freeze that area in the anterior part of the prostate. You just didn't treat that area. So so you can go and offer the patient another repeat focal therapy option. But I always say we're not burning any bridges. Right. Patients still can undergo radical prostatectomy and radiation, especially those patients don't have the same complications that we usually, or difficulty that we see, challenging case we see after radiation, because the treatment was focal. Yeah. So we know exactly where the disease is. I always tell my resident fellows, start on the contralateral side and go to the side that had disease, because you basically go from the known to the unknown side. So it's actually surgically, it's easier than those other post-radiation failures. Yeah.
And it's funny you mentioned that. I was just about to ask you, when we talk about salvage prostatectomy, at least in the post-radiation setting, it's not a positive topic. We worry about rectal injury, urinary incontinence, other potential injury to other potential organs. My experience has been that it's after focal therapy like cryo, it's really not that different than a native prostatectomy. Like, what has been your experience?
I agree, and that's also part of the reason it is easier, because it didn't work at the first, but because we were too focal. I think the initial experience of a lot of people who offer focal therapy, they stay very focal because they don't want to make it difficult, the radical prostatectomy that's going to come up. So I think especially those failures, oftentimes they're because we were very hesitant on being more aggressive with the treatments, but also it's different if you freeze tissue than radiate tissue. It's different if you burn with HIFU or use IRE than if you do radiation to the entire pelvis. So it's just a different nature, because the entire pelvis is radiated versus just the prostate.
Right. So just in closing remarks, is there anything else you'd like to tell the audience about focal therapy and the direction we're headed?
No. I actually trying to open people's minds and, bringing focal therapy into their armamentarium. I think it's a very important. We do it with bladder cancer, which is a way more lethal cancer. We do TURBTs. We didn't go if someone had a high-grade T1 disease and remove the prostate altogether and remove the bladder altogether. Right. We actually give them BCG, or if BCG fails, now the neoline treatments. And just think about it. There are higher failure rates in giving patients local installation therapies than with focal therapy. But we're so hesitant when it comes to the prostate. But on the other hand, I also don't think we should be cowboys and offer focal therapy to all patients. I think we should carefully select patients, but have an open mind to it when it gets to focal therapy.
Well, thank you so much for your time, Dr. Lebastchi.
Thank you so much.
It's always a pleasure.
Thank you, Dr. Saji. Bye-bye.